and epidemiology that perhaps weren't fully captured and reflected in the original 2015 guidelines. For example, the high birth rate and high percentage of the population less than 20 years, particularly in sub-Saharan Africa, where 25% of all Hep B surface antigen positives and then those less than 20, which contrasts strikingly with, for example, the situation in China, that liver cancers occur at a much younger age in sub-Saharan Africa, and the distribution of the viral load is different across the regions, in part reflecting the different genotypes. 75% of all those Hep B surface antigen positive in sub-Saharan Africa have a viral load less than 2,000. And also the emerging evidence base, the recognition increasingly that ongoing Hep B DNA integration, the oncogenic potential of this, and the epidemiology demonstrating the significant rate of ongoing new chronic infections through mother-to-child transmission in sub-Saharan Africa, and the MTCT is what really drives the chronic infection. And for the first time, we were starting to have more data from sub-Saharan Africa from cohorts. And then the striking access challenges, the very limited access to Hep B DNA in low and middle income countries generally, but particularly sub-Saharan Africa, and the low uptake of Hep B DNA in sub-Saharan Africa, 45% globally, 18% in sub-Saharan Africa. I think most in this audience will recognize that a distinctive feature of WHO guidelines, as opposed to the many other professional society guidelines, are our focus on low and middle income countries, that we really also target the national program managers in addition to the frontline clinicians, and the public health approach. That's the simplified and standardized approaches with preferred regimens rather than the more individualized treatment approach in professional society guidelines. And just to give you a sense of our methods and our approach with our guidelines is defining the topics, defining the question in a very structured way, and then commissioning the evidence base, be it systematic reviews, be it modeling, landscaping reports, and looking holistically, not just at the evidence, but that overall assessment of the balance of benefits and harms, looking at resource utilization, cost effectiveness, feasibility, values and preferences, and acceptability. And all this being what is presented to the guidelines development group to result in formulation of the recommendations and then rating of the certainty of evidence and the strength of the recommendations. So this is just to give you a sense of the amount of background work and commissioning that goes into these guidelines. You see all the systematic reviews on the different topics, the modeling work that was undertaken in a number of different areas, and then some great work on landscaping the diagnostics and the market that Chai led on. And then a series of values and preferences and acceptability surveys in the community and the patient population among healthcare workers. And this time we also did a survey among Ministry of Health, hepatitis focal points, to really get that perspective on reactions to potential new directions. And the guidelines development group process, so we take a lot of care and attention ensuring we have good regional representation, gender representation, and the critical role of civil society community representation, including those with lived experience. And we had excellent co-chairs and methodologists, and Saeed Hamid from Pakistan, and also Wendy Spearman, who's at this conference, but chairing another session at the moment from South Africa. So these were the key topics we prioritized for updating of the recommendations or new recommendations. So you'll be hearing about these in the subsequent slides. And this is the standard format in the guidelines. So when you go onto the website and access the full guidelines, every chapter follows this format: recommendations, background, summary of the evidence, and then that overall rationale for the recommendations, not just about the evidence, other considerations. And then very importantly, thinking about the implementation considerations. So what countries need to be thinking about to implement these recommendations, and then a section on research gaps. And the guidelines are divided into 4 subsections. This one shown here, the expanded treatment eligibility, with 6 chapters, another one on the Hep B diagnostics and delta testing, and then a third one on service delivery and monitoring. So moving now to the first recommendation. I think everyone recognizes that the use of non-invasive tests has become widely adopted as the gold standard for staging of liver disease, and the use of liver biopsy has long faded. And that these blood-based, one being a blood, 2 being blood-based tests, are widely accessible, available at low cost. And then also the transient elastography in certain settings that are less resource challenged. And so we had an original recommendation in 2015. In those guidelines, this was center stage. We wished everybody to have staging of their liver disease. But this was updated, and this is now a strong recommendation based on moderate quality of evidence, and the focus in these guidelines is on diagnosis of significant fibrosis. That is a big shift from the focus on cirrhosis in the 2015. The other important recommendation in the new recommendation is on the thresholds for determining whether somebody's got cirrhosis and significant fibrosis. Now, in 2015, we focused on cirrhosis and we used an APRI cutoff of greater than 2. Now, that was the upper limit of the options for the thresholds, but that only had a sensitivity of 35%, high specificity of 89%. And it became apparent in the years after the launch of these guidelines that a significant proportion of those with cirrhosis were being missed by this threshold being too high. So in these new guidelines, we are now focusing on significant fibrosis, not the later stage of cirrhosis alone, and we've gone with a low cutoff. And so it's a score of greater than 0.5, or if you have available transient elastography, greater than 1. And this is a strong recommendation. So what was the basis for this? Well, there were 219 studies in a systematic review comparing the diagnostic accuracy of this APRI and the transient elastography compared with liver biopsy for diagnosing significant fibrosis. And what is shown in the table on the right is what the sensitivity and specificity were. So it's 72% sensitivity. Remember, it was down to 35% with the previous cirrhosis threshold, and the specificity being about 65%. And the transient elastography was very similar. If you look there, if you used a high cutoff, that would go right down to 29%. So I think we got the balance right there. And what is helpful is to look at what the predictive value of a result would be in a typical clinical situation. So a hypothetical situation, 1,000 people assuming a prevalence of 25% of this significant fibrosis. And what you see is what the true positive rate would be, what the false positives, false negatives, true negatives. So you see in this cutoff, there's going to be quite a lot of false positives. But the view was of the guidelines group that that was acceptable. And if you used a high cutoff, your false positive rate goes right down, but you also are missing some of the true positives. So I think it's good for you to understand this tightrope, this balance between making these decisions. So how does this feed into the who to treat? So the who to treat, there are 4 main options for meeting treatment eligibility. You can meet one of them, you can meet some of them, you can meet all of them, but you only need to meet one. And first off, treatment is now recommended, as before, for all adults, but now all adolescents greater than 12 years. So this is a big change. And of course, by default, this is going to include pregnant women and girls and women of reproductive age. So, and this, as you will see in subsequent recommendations, is very relevant and complements the potential to expand antiviral prophylaxis. Number 1, so this evidence of significant fibrosis based on those thresholds of the APRI and the transient elastography that I mentioned, as well as also those with cirrhosis, because that's important for monitoring. So we have thresholds for cirrhosis. And this recommendation applies regardless of ALT and Hep B DNA levels. You don't need that to be able to start treatment. A further option, if you have access to Hep B DNA, is having a Hep B DNA greater than 2,000. That compares with 20,000 previously, together with an ALT above the upper limit of normal. Previously, we required at least 2 ALTs. So this is, again, saying at least 1 ALT above the upper limit of normal, and we specify those levels. But for adolescents, the requirement of at least 2. And this was also a strong recommendation for adults, conditional for adolescents, reflecting the much more limited evidence base. The third one, requiring no measurements, is really if there's evidence of co-infections, be it HIV, Delta, or hepatitis C, family history of liver cancer or cirrhosis, immune suppression, comorbidities, that can be diabetes or metabolic-associated steatotic liver disease, or extrahepatic manifestations, again, regardless of either the APRI score, Hep B DNA, or ALT levels. So strong recommendation for adults, conditional for adolescents, again, reflecting the more limited evidence base. And then the final option is in the absence of Hep B DNA, and this is the same recommendation we had in 2015, which was not really widely adopted, but we've retained it, is if in the presence of Hep B surface antigen positivity, you have a persistently abnormal ALT level, that again, regardless of APRI score, would be an option for starting treatment, although we do comment that this is really when you've excluded other causes of the raised ALT. And this was a conditional recommendation as before. So this is what the algorithm looked like in 2015. This is what it looks like in 2024, and a very streamlined process where the focus is much more on the who to treat. And it's only on the far right is that vertical arrows, that is that subgroup of those who you are recommending to defer treatment and monitor. And so this is one simple algorithm, everything together, including the monitoring. So what are the main messages here? Well, the main messages are we're expanding to include all age groups, so that's adults and adolescents, and women of reproductive age, women and girls, be they pregnant or non-pregnant. And that really allows a common entry point for treatment. So it's not just women, pregnant women, focusing on prevention of mother-to-child transmission. It's assessing the pregnant woman for treatment for her own health, as well as prophylaxis. And so the hope is that many more women of reproductive age will be on treatment for their own health. So when they become pregnant, they are already on treatment. And these 4 options of for treatment will capture a much higher proportion was the case previously, which was between 8 or maybe 20% of those Hep B surface antigen positive being eligible based on the 2015 criteria, to now at least 50% and probably 60 to 70% in some regions. And these are applicable to all settings, whether or not there is ready access to Hep B DNA or limited or no access. And the majority of the Hep B surface antigen positive will meet the treatment eligibility without the need for a Hep B DNA assay, and only one of the treatment options actually requires the Hep B DNA. And I think it's important to emphasize we're not de-emphasizing Hep B DNA. Hep B DNA will be extremely important for ongoing monitoring to ensure viral suppression. But this should not be the gateway and a barrier to accessing treatment. And again, just to emphasize that we really want the non-invasive test to be center stage, and in the algorithm, it's up there at the top. That's almost the first thing that needs to be done, because that is something that's widely available, and that is the group that also benefits the most from treatment if there's evidence of significant fibrosis. So what is the evidence base for this? This is just to give you a sense of the evidence base and considerations that fed into this recommendation, 2 systematic reviews and the modeling, and then I'll flag also the numbers needed to treat. And there was a comprehensive set of the acceptability values and preferences survey that there's insufficient time here to go into. So it is helpful because this is, and these are systematic reviews that we've shared with our sister or other professional society organizations like AASLD that is working on their guidelines, so that this evidence base is shared to those updating their guidelines. So this is the natural history of chronic hepatitis B according to Hep B DNA and ALT levels. The majority of studies were from the Western Pacific, but we did have 3 studies from Sub-Saharan Africa this time. And what this shows on these 2 graphs is the strata of Hep B DNA on the left bar, and what the incidence of liver-related deaths, HCC and cirrhosis are, and on the right, according to the strata of the ALT, from normal to 1 to 2 times greater than normal to more than 2 times normal. And you see on the left that dose-response relationship with a very low rate of events, not negligible in those with a viral load less than 2,000 or 200. That was very similar. And on the right, what you see is very low rates of events in those with normal liver function ALT, which is pretty similar between those between 1 and 2 times or greater than 2 times normal. That's the message there. The second systematic review was what is the effectiveness of treatment according to different Hep B DNA levels, ALT levels. And so this was based on 46 studies, almost all from the Western Pacific region, none from Africa, none from the EMRO region, mixture of randomized trials and observational studies. And the majority of the data is in those with higher viral loads. We really have a lack of an evidence base in the low Hep B DNA levels, and that's a research gap. So not surprisingly, this showed higher treatment efficacy at higher baseline viral load in ALT, with much better quality of evidence at the higher viral loads. And then I think a very nice sort of public health approach is to calculate the numbers needed to treat. How many people do you need to treat in order to prevent one case of liver-related death, cirrhosis, and HCC. And just looking at the third column for the HCC, so less than 2,000, you'd need to treat 210, 2,000 to 20,000, 59, 20,000 to 200,000, 14. So for those of you from Ministries of Health and with the public health perspective, this is an important reality check in terms of implementation. Turning now to the first-line antiviral therapies, in 2015, we had recommended tenofovir and entecavir, both drugs with a high genetic barrier to resistance, as the preferred regimens. So now in these guidelines, we're also recommending the option as alternative regimens, dual regimens, tenofovir with 3-TC, tenofovir with FTC, where tenofovir monotherapy is not available for whatever reason. And even if this is just as an initial strategy while access to tenofovir monotherapy is being secured. Strong recommendation. And then also for the first time, we're recommending for those persons with osteoporosis or renal impaired kidney function, the option of entecavir and TAF. And also for children and adolescents, entecavir has regulatory approval in those greater than, actually it's 2 years, and TAF greater than 12 years. So the evidence base for this, we did 2 systematic reviews comparing TAF versus tenofovir, and another one of dual therapy versus tenofovir. And broadly, similar outcomes in terms of the effectiveness with the viral suppression, ALT normalization, but the TAF versus TDF, less issues with the renal impairment and bone mineralization, but these were very small differences. And the main message is that we recognize that in some countries, there just was not the registration and the access to the monotherapy. And so, but there was access to the dual therapy through HIV ART programs. And so this was to give, again, ensure ready access and a further option. Turning now to prevention of mother-to-child transmission using antiviral prophylaxis, there's been a number of sessions on this at this conference. 2020, we'd recommended where Hep B DNA or e antigen is available, prophylaxis is recommended for those with a Hep B DNA greater than 200,000 or a positive e antigen. And then the new 2024 recommendation, recognizing the reality on the ground that there's often a lack of access, any access to Hep B DNA, particularly in ANC settings and even e antigen assays. And so giving countries the option as a conditional recommendation to offer antiviral prophylaxis to all Hep B surface antigen positive pregnant women. This was conditional recommendation. And so we're recommending this can be as early as possible, second trimester of pregnancy until at least delivery or completion of the infant vaccination series. And of course, this needs to be alongside the center stage recommendation of infant vaccination and birth dose. And this is the algorithm, and you can see the pink ones are, the 2 boxes are where you've got access to Hep B DNA or e antigen and where you don't. And then really importantly, ensuring that the mothers are assessed for treatment for their own health. It's not just all about prevention of mother-to-child transmission, and that's key. And rationale for this, well, in the 2020, we had a systematic review that really, and this has been shown multiple times, the very strong protective effect of antiviral prophylaxis alongside the vaccination, and no transmissions when the viral load is less than 200,000. But we recognize the real challenges in access to Hep B DNA e antigen, and that meant many women weren't getting anything. And so that was the driver with this new recommendation. recognizing we didn't have any empiric data, we didn't have any studies really evaluating the impact and feasibility of this approach, but we did have modeling of this prophylaxis for all. And the main message from that modeling was that universal birth dose still remains the one which is going to have the greatest impact, with an estimated 4.9 million infections, neonatal infections averted, and that universal prophylaxis would only be cost effective probably in about 40% of the 106 countries that were evaluated. And the relative cost effectiveness for countries between universal or a Hep B DNA-driven strategy will depend on the cost of treatment, the cost of diagnostics. So these are really considerations for countries. Turning now to the hepatitis B, DNA, and the Delta recommendations. So as we did for the Hep C guidelines, really important other options for the expanding the simplification and access to diagnostics. So the recommendation that Hep B DNA point of care assays can be an alternative to the lab-based assays to determine eligibility for treatment and monitor treatment response, conditional recommendation. And then a really important strategy that we really promoted with the Hep C guidelines was reflex Hep B DNA testing, as we had reflex Hep C RNA testing. And that simply means, and this is a strategy to promote linkage to care and treatment. So it means that if you've got a Hep B surface antigen positive result in a lab, you can use that same sample or a duplicate sample to immediately reflex to a viral load. And similarly, if you're in a clinic and you're doing an RDT and it's positive for Hep B surface antigen, you immediately take another sample for viral load. It really, this is an intervention that can significantly reduce the loss to follow-up. We had 3 systematic reviews. The diagnostic accuracy at the point of care viral load is very good. The clinical impact showed a higher uptake of the viral load testing and of treatment initiation. And the clinical impact of reflex testing again showed a high uptake of Hep B DNA testing and reflex and treatment initiation. There was often a lack of a comparator arm in these studies. Moving now to Delta testing. As you know, Delta is a very important co-infection and main contributor to morbidity and mortality. And this is the first time we were very keen to have recommendations about who to test, how to test, while recognizing we weren't yet at a point to be able to offer specific treatment recommendations. So the approaches really on testing were advocating for a universal testing approach where all those who are Hep B surface antigen positive get serologic testing and as a preferred approach to promote access as a conditional recommendation, but recognizing that there will be many settings, at least now, where a universal antibody testing approach is not feasible because of laboratory capacity or limited resources. And so ensuring that priority is given to populations that are at higher risk of having Delta infection, those from endemic countries or regions, those with advanced liver disease, those receiving treatment already, and those populations we know are at higher risk, hemodialysis, those who inject drugs, and men who have sex with men. So both conditional recommendations. We recognized there were no studies that had evaluated or done cost-effectiveness analysis of these different approaches, but observational studies, mainly from high-income settings, had shown that with the risk-based approach, there was often a poor testing uptake. And where particularly the reflex approach had been adopted, so it was much more, which reflects the universal testing approach, that really had helped increase the uptake of Delta testing. And important that given the treatment landscape is evolving with Delta. It's not just about the treatment, but effective case finding means improved monitoring, prevention of ongoing transmission, and better surveillance for liver cancer. And in terms of how to test, this is pretty straightforward. It's serology followed by a NAT test for detecting active viremic infection. And many of the commercial serology and molecular PCR assays were shown to have good diagnostic accuracy and correlated well with each other. And the main limitation is really that there was a lack of a gold standard assays and the absence of an RDT for Delta serology. Reflex testing, again, a really important intervention, and there's a double reflex. The double reflex being those who are Hep B surface antigen positive, automatically getting Delta serology, and those who have positive Delta serology automatically getting the Delta RNA. A conditional recommendation. So we did systematic reviews in this area that showed the two steps in that reflex testing with this reflex approach, increased serology testing uptake compared with non-reflex, 97% versus 45%, and a very high uptake of the second part of the reflex as 98%. So this was effective. The final part is really on the service delivery and the monitoring chapters, and they were pretty much the same as what we had for the monitoring, at least in 2015. So we recognize we did not have the evidence base as yet to make formal recommendations, as we had done with hepatitis C, on decentralization, integration, task sharing, some of the kind of key tenets of a public health approach. And so we came up with some guiding principles or approaches, and 8 that really we wanted to make clear should be embedded in every clinical service, facility level program for hepatitis B. Strategies to strengthen linkage, and that used recommendations we already had from 2017, where we had very specific recommendations, peer support, use of dry blood spots. And then recognizing, and you'll see in a minute why this is so important, strategies to promote and sustain long-term adherence, and building on everything we've learned from HIV programs, text reminders, peer counselors, strategies to promote retention in care, again, hugely important in HIV programs, the importance that we build on that with the patient trackers, and moving towards opportunities for integration with, be it HIV services, primary care, decentralization, that move towards that to promote access to care, increasing task sharing, and that requires a differentiated care approach. We have a very effective differentiated care model for HIV, those patients who are stable, managing at low-level facilities, and those with more complex problems may needing some more specialist support. And I think we still have a lot to work through this to come up with the optimal differentiated care approach and the critical importance of community engagement. So I've already mentioned we had a limited evidence base, and this is an important research gap that needs to be approached. So we used a bit of a combination. We used a systematic review with hepatitis B, but we very much used the existing reviews on adherence support retention to guide us from HIV to guide us in hepatitis B. Main messages on the service delivery. The models that are out there for Hep B service delivery are still at an early stage. We still remain rather at the specialist level, hospital-based type models of care. But we did find some increasing number of examples of co-managed between primary care and specialist, integration with HIV, some primary care models. So this is really the first tranche of studies that are kind of more looking to the future about service delivery. This is just to give you a quick snapshot of the reality of the literature that was out there. And this is just on 69 studies with a traffic lights mapping, which shows what data was available for these studies across the cascade of care, with green being where it's available, red where it's not. And green, the left being the early part of the cascade, the right being the later part of the cascade. You could see huge gaps with only 9% of studies having monitored viral suppression, 16% retention. And then the overall message from these systematic reviews was, this is the data we have on the cascade of care. So significant attrition across the cascade of care. So of those where eligibility was assessed, that only 50% of those deemed eligible were started on antiviral therapy, only 36% retained in care, and 23% with Hep B DNA suppression. The retention in care was much lower in those not on antiviral therapy and lower in those managed in primary care. So we have a major challenge, and this is why it was so important to ensure a focus on adherence and retention in care. And this is just an example of how we can learn from and build on what we have done in HIV and apply that to hepatitis B. So final slide, implementation priorities. Case finding, case finding, case finding, hugely important. There needs to be, if we're to benefit from these new simplified recommendations, we need to have improved case finding. We're very much working with countries to be the early adopters and champions of these new guidelines. And it's very exciting to hear those of you who are wishing to swiftly move forward in your countries to adopt and adapt and implement these guidelines. We need to have good awareness raising and working with the community to educate the community, and also healthcare worker training programs and the opportunities to ensure that the best prices are being obtained for the drugs and the diagnostics. Across all these different chapters, we've got good sections on implementation considerations and research gaps, so that you should be aware of those, and to thank the many, many people, guidelines group, external review group, systematic reviewers, modelers, and the community have played such a key part in this. Thank you very much, and happy to have questions.